Welcome back to Clinical Hematology Reviews. Today we'll be discussing RBC indices. We begin with the normal red blood cell morphology, specifically the normal mature erythrocyte, often called a discocyte. Under standard conditions, a normal mature discocyte is a biconcave disc measuring 7.0 to 8.0 micrometers in diameter. When evaluating erythrocyte volume on an automated analyzer, this corresponds to a normal mean corpuscular volume, or MCV, of 80 to 100 femtoliters.
Exactly. When you are performing a microscopic examination of a peripheral blood smear, a great internal reference for size is the nucleus of a normal, resting small lymphocyte. The diameter of a standard normocytic red cell should be roughly identical to that nuclear diameter. Microscopically, the normal discocyte displays a distinct central area of pallor that occupies approximately 1/3 of the cell diameter. This pale center is surrounded by a smooth rim of pink staining hemoglobin when visualized using Romanovsky or Wright stains.
That structural ratio is critical because alterations in size and hemoglobin content dictate our clinical approach. Size variations like microcytosis, macrocytosis, and overall anicytosis are quantified using the MCV and the red cell distribution width, or RDW. Meanwhile, hemoglobin content, such as hypochromasia, is evaluated by gauging the size of that central area of pallor. We then correlate those visual microscopic findings directly with the automated mean corpuscular hemoglobin concentration, or MCHC.
That brings us directly to anisocytosis, which is defined as an abnormal degree of variation in red blood cell size within a population. To characterize size quantitatively, we rely on automated red cell indices, starting with the MCV to define average cellular volume. Cells with an MCV under 80 femtoliters are microcytic, those between 80 and 100 femtoliters are normocytic, and those exceeding 100 femtoliters are macrocytic. However, the MCV only gives us an average value, which is why we must also look at the RDW to evaluate volume distribution.
Precisely, the RDW quantifies the degree of heterogeneity in RBC size across the sample population. The normal reference upper limit for the RDW-CV is typically less than or equal to 14.6%, or roughly 15.0% depending on the laboratory. An RDW greater than 14.6% signals significant anisocytosis, indicating a mixed population of small, normal, or large cells. It is mathematically calculated as the standard deviation of RBC volume divided by the MCV multiplied by 100.
That mathematical formula highlights a key technical concept in the laboratory. Because the MCV sits in the denominator of the RDW-CV calculation, a markedly low MCV can mathematically inflate the resulting percentage even if the absolute standard deviation of cell volume stays constant. That is why an elevated RDW flagged by an automated instrument should always be confirmed visually. We must review the peripheral blood smear to verify true variation in red cell size.
Turning our focus to microcytes, these are defined as red blood cells with a diameter less than 7.0 micrometers and an MCV of less than 80 femtoliters. Microscopically, microcytes typically display hypochromasia, presenting with decreased MCH and MCHC values due to reduced hemoglobin production. However, it is worth noting that microcytes can occasionally remain normochromic depending on the underlying pathology.
A fascinating variation of the microcyte is the microspherocyte, which occurs when a microcytic cell loses membrane surface area relative to its volume. This membrane loss forces the erythrocyte to adopt a compact spherical shape rather than a biconcave disc. Because a normal quantity of hemoglobin is concentrated into a significantly reduced volume, these cells lose their central pallor entirely. On a stained smear, microspherocytes appear smaller, rounder, and intensely densely stained, often referred to visually as hyperchromic.
Next, we have macrocytes, which are defined as red blood cells having a diameter greater than 8.0 micrometers and an MCV exceeding 100 femtoliters. Unlike many microcytes, macrocytes typically contain an adequate total mass of internal hemoglobin. Consequently, their associated automated indices reflect a completely normal MCHC between 32 to 36 grams per deciliter.
That is an important distinction to highlight for overall index interpretation. Because macrocytes have a significantly larger individual cell volume, the total amount of hemoglobin per cell increases proportionally. This results in a normal to elevated mean corpuscular hemoglobin, or MCH, while the concentration metric, the MCHC, stays within physiological limits. Macrocytes simply expand the physical container without diluting the concentration of hemoglobin inside.
Let us now examine chromasia, which is the microscopic evaluation of cellular hemoglobin content correlated with the automated MCH and MCHC. Normochromic erythrocytes exhibit a central pallor occupying roughly 1/3 of the total cell diameter. Their corresponding quantitative values fall into reference ranges of 28 to 34 picograms for the MCH and 32 to 36 grams per deciliter for the MCHC.
Conversely, hypochromic cells feature an expanded central pallor that takes up significantly more than 1/3 of the cell diameter. This microscopic appearance correlates with an MCH below 28 picograms and an MCHC below 32 grams per deciliter. Hypochromasia is a classic hallmark of disorders characterized by defective hemoglobin synthesis. Common clinical etiologies include iron deficiency anemia, or IDA, various forms of thalassemia, and other disruptions in heme or globin production pathways.
On the opposite end of the spectrum, we observe cells described visually as hyperchromic or dense spherocytes. In these cells, the central pallor occupies less than 1/3 of the diameter or is entirely absent. The automated indices show an MCH greater than 34 picograms and an MCHC exceeding 36 grams per deciliter. However, we must emphasize that true physiological hyperchromia does not exist in living red cells.
That is a critical physiological principle in laboratory science. An erythrocyte cannot physically be oversaturated with hemoglobin beyond approximately 36 grams per deciliter. What appears visually as hyperchromia is actually an artifact caused by a loss of red cell membrane, such as in spherocytosis. Concentrating a standard amount of hemoglobin into a smaller, spherical shape reduces membrane surface area and creates the dense optical appearance without true solute oversaturation.
Finally, we evaluate polychromasia, which reflects the presence of residual cytoplasmic ribosomal RNA in immature erythrocytes. Polychromatophilic red blood cells, or reticulocytes, represent the non-nucleated stage immediately following the orthochromic normoblast in the bone marrow. On standard Romanowski or Wright stains, these young cells appear larger than mature erythrocytes and exhibit a distinctive bluish-gray coloration.
That characteristic bluish-gray tint on the Romanowski stain is caused by the lingering ribosomal RNA machinery actively synthesizing hemoglobin before full cell maturation. From a clinical perspective, identifying increased polychromasia on a peripheral blood smear indicates accelerated bone marrow erythropoiesis, known as erythroid hyperplasia. The marrow is rapidly releasing young reticulocytes into peripheral circulation to meet systemic demand.
Increased polychromasia typically occurs when elevated circulating levels of erythropoietin, or EPO, stimulate the bone marrow compartment. Physiological triggers include systemic tissue hypoxia, acute hemorrhage, or states of shortened red blood cell survival such as hemolytic anemias. Identifying polychromasia provides immediate microscopic evidence that the bone marrow is responding appropriately to peripheral erythrocyte loss or systemic oxygen deprivation.
Today, we reviewed red blood cell morphology, indices, and their clinical interpretation.
Excellent review today. Thanks for joining us.